welcome to Coffee with Coker, a healthcare business podcast published by the Coker Group. My name is Mark Reibold. I'm the host. Espresso Shots are smaller versions of the Coffee with Coker podcast. And today's episode is on physician compensation trends, and we're specifically talking about comp trends for hospitalists. So this is a fairly specific topic, but it is one of those topics that we get a lot of questions about in our compensation related work. And so to answer it, we have brought in Justin Chamblee again, who's been on a couple of other episodes in the past, but Justin is a senior VP at Coker, and he heads up all of our compensation related services. So he's definitely one of the premier experts in the area of physician compensation around the country, and works with all kinds of organizations, from hospitals and health systems to independent and private medical groups, and really anything in between as it relates to compensation. So as I said, we had a lot of questions on this topic, and we thought it made sense for us to have a specific discussion talking about compensation trends, but also kind of forms of measuring compensation and production as it relates to hospitalists, which obviously are unique compared to other specialists or other types of arrangements. So it's a great discussion. We hope you enjoy it. Before we close out, just want to remind everybody, please follow us. You can follow us on social media. You can subscribe to the podcast, and you can find past episodes, all of our episodes of the podcast at coffeewithcoker.com. or via the main Coker website at cokergroup.com. And you can follow us on Twitter. That's at Coker Group. You can find us on LinkedIn as well. And we also want to encourage all listeners, anyone interested, to submit feedback. So you can send messages via the website or via email directly at feedback@cokergroup.com. And we welcome your questions or suggestions for future topics, or just any commentary, feedback related to anything we've talked about or that you'd like to hear about in the future. With that, we'll jump right into this discussion with Justin on physician compensation trends for hospitalists. Today, we are talking about compensation trends for hospitalists. So a lot of this is going to be primarily relevant for hospitals and health systems that are either already operating a hospitalist program, which is many, if not most, systems out there. But also, if you're thinking about expanding your program or launching a new one, this is a frequent question we get from clients and people out there in the marketplace. Different questions related to compensation for hospitalist programs. And so I guess just diving in terms of introducing the topic, we have Coker's senior vice president over compensation services, and really I think one of the best experts out there on all things physician comp related, Justin Chamblee. So welcome back, Justin. You've been on the podcast a few times.
Thanks.
We'll jump right into it in terms of why this is relevant and where some of the questions come in on compensation for hospitalists.
Yeah, so I think one of the key challenges with hospitalist models is defining what the work expectations are. With so many other specialties, we are looking at them based on production. And sometimes the notion with hospitalists is that we're not focused on production. And I would say that's not necessarily the case. We're just looking at a different measure of production, meaning instead of looking at wRVUs, we are looking at hours or shifts worked. And so we're still measuring productivity for hospitalists. It's just a different measure. And I think one of the key focal points that we look at is trying to define what a normal level of production or normal level of hours or shifts work would be for a hospitalist. And there's a lot of data out there surrounding hospitalist medicine programs. One of the key sources that we look at is the Society of Hospital Medicine survey that is put out. But really, we've developed some of our own benchmarks as well. One of the key metrics that we look at for hospitalists is the staffing of a 7-on, 7-off program. And that means physicians are working 7 days on, have 7 days off. Typically, they're working 12-hour shifts on those 7 days that they're working. And when you do the math, 7 days on, multiplied by 12-hour shifts, through roughly 26 cycles a year equals roughly 2,184 hours per year. And so oftentimes that is seen as the benchmark for physician staffing in terms of the number of hours worked per per year. For our internal purposes, we typically set that benchmark slightly lower. We look at roughly 2016 hours per year, which equates to 14 12-hour shifts per month. And so when we are doing our analysis, that's really what we're looking at. And where this comes into play is in assessing benchmark data. Most of the benchmark data is published on an annual basis, meaning how much is the total cash compensation for a hospitalist on an annual basis. What we need to do is break that down into an hourly or shift-based rate. And so we're taking that benchmark data, dividing it by the 2016 hours to get to an hourly rate. Then we can multiply that by 12 hours to get to a shift-based rate. So I think that's a key consideration with respect to hospitalist models, is still this idea that productivity is important, yet it is defined based on hours, not wRVUs generated.
Sure. Is the 12-hour shift kind of the standard, or what are the alternatives there?
I would say by and large it is the standard, Mark. We do see some programs out there that staff on a 10-hour shift basis. From my experience, that tends to cause more operational challenges than it provides benefit. One of the things that the physicians like about a 10-hour shift model is the fact that the day is not much longer on a 10-hour shift than if they were working a normal 8-hour day. The problem that we run into is if you still define a full-time schedule as roughly 2,016 hours or even 2,184 hours, when you're working 10-hour days, that's a lot of additional days to work when compared to a 12-hour shift model. And so what we find from an operational standpoint is the physicians like the 10-hour shifts, yet they don't like working the sheer number of days that is required to meet a full-time expectation under that model. And so I think that's why we see most gravitating to a 12-hour model, that 7 on, 7 off, or some other inference of that, because of the fact that it gives more time off between the number of shifts worked.
Yeah, that makes sense. And I know too, when we're looking at other specialties and other coverage models, whether it's call or other types of coverage, not all shifts, not all coverage is created equal. So is that apply here in terms of day versus night shift and how that may differentiate?
Yeah, that's a great question, because that is one of the challenges that comes up in hospitalist compensation arrangements. Not every program, but many programs, especially at hospitals of any size, are staffing hospitalist models 24/7, 365, which means you've got physicians on site both during the day and during the night. Typically, especially as you get into larger programs, the number of physicians on during the day far outpaces or exceeds the number of physicians on during the night, but it's still important in those programs to have physicians on during the night. And the challenge is, how do you address those less desirable shifts? Meaning, most physicians don't really want to work night shifts. It's a drain on the body. It is counter to sort of their daily flow.
Quality of life.
Yeah, quality of life.
Yeah.
I mean, some perhaps like it. You can find those rare breeds that do, but most don't really care for it. And so, how do you address that? And we've seen hospitals really take two approaches to addressing it. One is either through an equitable shift allocation, meaning they look at all their hospitalists and say every hospitalist has to take the same number of day shifts versus night shifts. The other approach that hospitals take is providing either a night shift differential, meaning they're paying more for that night shift, or they are hiring physicians specifically to cover the night shift and paying more for that coverage because of the lack of desirability associated with it. Either of those models work, but when we get into paying a premium or a shift differential for the night shift, what we always focus on is, and this is getting back to the compensation piece, is when you look at the benchmark data, there's very few respondents to the nocturnist category, which in my mind means that most of the physicians in that main hospitalist category are working night shifts as well. And so when that is the case, we have to assume that those physicians are working night shifts, thus the value or the quote premium associated with the night shifts is baked into that baseline data. And so typically what we do is if we apply a 20% premium, let's say, to the night shift, we're going to go back and reduce the value for the day shift such that the overall shift-based rate that we are paying stays within market.
Yeah.
Exactly. And so then if all the physicians are working an equitable number of days and nights, compensation is the exact same. If you have certain physicians who are only working nights, other physicians only working days, when you look at the program collectively in terms of the total hours staffed, you're still coming up with that same effective shift rate. Mm-hmm. And so I think that's the key is making sure that we're designing the model to appropriately allocate the value associated with the shifts.
Yeah, so definitely some nuance there for sure. One of the other things I wanted to make sure we covered on this topic was, when we're looking at, I guess, if you want to call them traditional comp models, but you alluded to earlier, kind of a wRVU, productivity generated measurement and model. It's relatively easy to figure out the appropriate levels for incentives. So whether it's production bonuses or hitting certain thresholds, things like that on production. What about incentives when you're talking about hospitalist programs where the metric for measuring production is very different?
Yeah, that's a great question as well. And it's something that we face a lot. And one of the things that we have noted with hospitalist programs is while some are structured as wRVU-based models, that's not our preference. I mean, we see hospitalists as serving a function that allows for greater throughput, reduced length of stay in the hospital, better coordination of care. And if we think about a function of a hospitalist in that manner, incentivizing productivity can somewhat be counterintuitive, meaning if we're incentivizing production, we may be incentivizing a physician to do more versus do what is needed and then get the patient out the door. And so we really lean somewhat away from production incentives and hospitalist models and really tie the majority of incentives to more of the qualitative metrics, looking at length of stay, looking at readmission rates, looking at throughput, discharge timelines, patient satisfaction, other coordination of care metrics, really things that the hospitalist can influence that truly add value to the program. The one caveat I will note, though, is we do see production incentives creeping in occasionally. And that is really more so in programs where there is, for whatever reason, and I think it's a cultural issue in certain programs, where you've got certain physicians working a lot harder than other physicians. And so, that's always the challenge when you're paying on a shift basis is you've got physicians who are working at different levels of production, yet they're being paid the same amount. And so we have seen some models that provide some level of kicker. It's a minor piece of the overall incentive structure, but some level of kicker to reward excess production during a shift. And sometimes that's more so or better measured via how many patients that physician is managing versus how many wRVUs they're generating. So production still can make its way into the incentive, but it's very different than, say, how we're compensating a general surgeon or a family medicine physician.
Yeah. But I think that your point you made about the quality piece is critical because the hospitalists are so pivotal to the facility or the system being able to be that kind of key point for driving quality, implementing some of those quality improvement programs and some of the value-based care type metrics that you're going to see on the hospital side. Hospitals are going to be absolutely essential to that, even maybe like one of the key components of that.
Absolutely. I mean, they are sort of the quarterbacks of the inpatient service. And so properly incentivizing the hospitalists to do what they can do best, I think benefits all parties.
And from a fair market value standpoint, that's perfectly reasonable to incorporate some of those, whatever the metrics are, as long as they're reasonable to that individual case.
Yeah, absolutely. And I think it brings up a good point that we can touch on real quick. And that is, how do we assess fair market value when we're talking about a hospitalist model with other physicians, as we talked about earlier, family medicine physicians, general surgeons. Oftentimes we're looking at total cash compensation, also perhaps the effective rate per wRVU. From our vantage point, the dynamics really don't differ with a hospitalist, but instead of looking at the effective rate per wRVU, we're looking at the effective shift rate. And the dynamics with a effective shift rate are no different than a rate per wRVU, meaning if the effective shift rate creeps up too high, there could be a fair market value issue, even if total cash compensation is not at a high level, meaning we're still using a high rate of converting production, in this case hours, to compensation, which is potentially creating fair market value issues. And so really the same sort of thresholds, the same metrics that we use for evaluating wRVU-based models, we apply to shift-based models, with the key caveat being it's based on hours, not wRVUs.
Yeah. Well, this has been extremely helpful. Obviously, this is something that we could probably talk about for a long time and go. There's a lot of nuance, obviously. And so I'm sure there will be specific questions. Just, I guess, real quick, and it's kind of a closing, any general recommendations if you're a health system that is doing something with your hospitalist program, any like key recommendations to look for or things that, are kind of common pitfalls, when they're going through this process and trying to figure some of these questions out?
Yeah, I'd say 2 closing points. Number one, looking at the incentive structure and stepping back and saying, is the incentives that we have for the hospitalist program truly aligned with what they can do most to add value? And I don't perceive wRVU-based models to be that. So I think that's one key takeaway. The second is, and it's more of a fair market value related dynamic, but truly understanding the economics of the dynamics of your hospital-based arrangement, and understanding, okay, what is the effective shift rate we're paying? What is the total cash compensation per shift that we're paying when all incentives are baked in as well? And, are we looking at those no different than we are looking at a wRVU-based model in terms of where those effective shift rates fall from a benchmark standpoint, and just making sure from a compliance standpoint we're in the appropriate ranges there.
Yeah, good points. All right, well, this has been extremely productive, and I know we'll talk more about this in the future. But if there are specific questions, we encourage everyone to reach out to us. And if there is anything else that we didn't cover on this topic or anything else, as always, feel free to let us know, and we will make sure to cover it. But thanks again, Justin, for joining us, and we'll look forward to hearing from you on a future episode.
Sounds great. Thanks.